So, hello everyone. Welcome to our January 2020 Echo session, the first one of the year. And we are glad today we are hosting from a different side of the world. We are in West Africa, Sierra Leone, particularly in Freetown, together with our colleagues here, Francis, Dr. Mariam, Dr. Collins here, and Sylvester. So we are glad to be here as we are about to have one of the important topics that we have in the year. You know, we met a few months ago in Addis and discussed a lot about our priorities for the year in terms of lab system strengthening. We talked things that included things like demand creation, result utilization that we have always talked about. We also went into depth with issues regarding network optimization, diagnostic integration, point of care, and conventional instruments. How do we bring them together to the benefit of the patient at the same time at a cost-effective issue? And we have depth regarding waste management. And what we are also glad is we had a similar session last December for the Global Fund, and they all touched on these issues. And today we have PEPFAR coming through to also tell us what are the opportunities that are there in COP20 as we all fight together to fight the tide of HIV across the continent and across the globe in general. So today, kindly, as we always do, kindly register your presence in the chat box by writing your name and organization. If you are more than one at a station, kindly, as usual, register your names and organizations from which you come from. And remember, our session is going to be 25 minutes to 30, followed up by a question and answer session where we will be chatting about what would have been presented. Today we have an esteemed speaker. We are hosting Dr. George Alemnji. Dr. George Alemnji is the Senior Technical Officer for PEPFAR Laboratory Services from the Office of the Global Health AIDS Coordinator, OGAC. Dr. George is going to take us through the PEPFAR priorities in terms of lab system strengthening for COP20. George, kindly share your slides and over to you. George, are you there?
I'm there. 1 minute.
Thank you. So whilst George is getting ready, those that are just joining, kindly register yourselves in the chat box, enter your name and organization, and kindly keep your mic mute if you are not speaking. Thank you.
Are you getting me?
Yes, we are getting you. You need to put the slides in presentation mode.
Let me see what is going on here. What am I not doing here?
We can see your screen, but it's not yet in presentation mode.
Oh. So
now we can see your desktop.
Okay, let me go all over again. So, oh, what am I not doing here? So,
We can see the email now.
okay, so let me.
Probably maybe if you reopen it again and then share.
Okay.
Welcome those that are just joining. Kindly register your presence in the chat box and the name and organization.
Hello, my name is Alfons Krug. I'm from Human company in Germany.
Thank you, Alfred. Kindly register your names in the chat box, names and organization, and kindly keep yourselves mute if you are not speaking. George, are you managing?
Hi, Anafi. I think you have the slide set. Why don't you display from that side?
George, if possible, you can forward the slides, then we can share from the side. Please share.
Are you seeing me now?
We can see your screen, but you need to minimize that Zoom, and then you put it on presentation mode. We're also
Okay.
trying to see if we can be able to share them from this side. If that works. Yeah, I think let's go.
So, okay. Are you there?
Yes, although maybe you may need to go to display settings, and then we can see only one top left.
Are you seeing my screen?
Yes, we can see it, though it has two slides on it. Can you go to display setting at the top left corner of the screen?
Okay.
All right.
Are you seeing me now? Is it okay now?
Probably
Can I go?
just try to share it from this side.
Can I go ahead?
Yes, George, you can go ahead.
Yeah, go ahead.
Okay, okay. Sorry for the delay, everyone. Good morning, good afternoon, good evening, everyone, depending on where you are. As Anafi has introduced, George Alemnji. I serve as a Senior Technical Advisor for Laboratory Services within the Office of the Global AIDS Coordinator in Washington. I'm here to present the lab systems strengthening priorities within our current COP20 that is ongoing. So I will start with definition of PEPFAR and also the PEPFAR, some of the achievements so far. This will take us through some of the country operational plan. Every year we'll talk about COP, what is it all about? And of course, some of the strategies that we've had in place in the past. And I will end up with laboratory priorities that are supposed to be in the current COP that is ongoing. And then, of course, there will be room for questions and answers. So the PEPFAR program has been going on for over 17 years. It's actually started in 2013. And within this period, a lot has been achieved. There has been up to more than about $85 million of investment just to support the Global AIDS program in general. And of course, just within this sort of huge financial support, the PEPFAR program has actually supported life-saving antiretroviral treatment for over 15.5 million people. These also include more than almost 700,000 children. There is a strong support for what we call the OVC programs and the DREAMS program, where there has been over probably 6 million children and orphans and vulnerable children supported through this program. Then, of course, we heard about the voluntary medical circumcision, the VMC, which has benefited over 22 million men on HIV prevention strategy. For those who have been with the PEPFAR program for a while, we appreciate that PEPFAR 2 was really centered on system strengthening. And during that time, there was a lot of support to strengthen institutions. I want to say here that the African Society of Laboratory Medicine that is hosting us today was actually established with strong support from PEPFAR. There was also a lot of support for infrastructure. Laboratories were constructed, instruments procured, a lot of training, and also quality system improvement. I'm sure the SLAMTA is still very, very fresh in our memories, and so many other things that has happened over the years. Moving forward, PEPFAR continue to provide this support, but in a more streamlined manner. Not a lot of investment again on infrastructure, because the expectation is that all the past investment should be leveraged now to support programs moving forward. Now, my next slide is talking about what is COP, because every year I talk about COP. So COP is actually the Country Operational Plan put together by PEPFAR is an annual cycle program that we use every year. It helps, of course, to link the investments that the U.S. government is providing to resorts. It provides an opportunity for analysis and also to determine how the program is informing gaps and filling of these gaps and engaging stakeholders. I just want to say here that this is a very, very inclusive process that involves us, the PEPFAR staff, both headquarters and field team, and also the Minister of Health and all the stakeholders. Down the road, I will be able to explain some of the timelines for PEPFAR program, but just to know that the COP process starts with a draft COP guidelines that we put together. It goes out to what we call the public view. Everyone sees it and comments, and we take your comments very, very seriously. They are incorporated, and the final version of the COP guideline goes out. The COP 2020 just went out last week, January 15. That is usually the day that it goes out. And next steps, we require in-country, what we call in-country meetings or retreat that brings together all the stakeholders, Global Fund, WHO, UNAIDS, together with country teams and Minister of Health, to put together a draft COP guidelines for the country that eventually will meet together with the country teams, review, and eventual approval. So we have what we call the PEPFAR 3 guiding principles. That is what I'm showing now, really centered on accountability, transparency, and impact. This is really what guides the entire program. At this point, let me just present some of the contextual issues that we are seeing, and most importantly, part of the data that we analyze showing progress made so far and some of the gaps that we expect to see field move forward. But most importantly, in the COP this year, which is a little bit new, is what we call the client-centered care. We know that it's been very, very difficult for programs to really get results out there, but as a requirement for this year and new to this COP, we really want to ensure that every patient receives his or her valuable results in addition to a copy that goes to the facilities or to the patient file. I think the notion here is that if patients receive their results, they are more likely to take this result to their doctors. So this is new for our program. And of course, I think that is something that everyone wants to see happen. So in terms of, again, lay more emphasis on the patient care approach, there is a strong, continuous strong support. Can people who are not presenting, can you mute your phones? Or your, yeah, some noise from the background? Good, 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 thank you. So again, there's a strong emphasis on community engagement to increase patients' demand for both viral load and early infant diagnosis. Of course, over the years, challenges of turnaround time, we really want to see that improve, making sure that results are returned to the patients, of course, a copy to the patients, and make sure that the results are acted upon. And of course, a quick action on the non-suppressed. I will explain this later. I think the non-suppressed population is becoming something that we need to pay more attention to. And of course, reinforcing enhanced adherence counseling, and of course, repeat testing for those who are not suppressed. And of course, Kenya has established a viremia clinic that is working so well, and I think we've seen that in other countries. So one of the patient-centered approaches, again, particularly for those who are not suppressed, is to establish the viremia clinics, and also to establish what we call the high viral load cascades. Now, I really want to emphasize from this slide moving forward that the PEPFAR program is really, really data-driven. We lay a lot of emphasis on data collection, cleaning, analyzing of the data to really show the program impact. This slide is actually showing a huge improvement that has been obtained over the years with viral load testing coverage. You can see that we're showing 3 years here from FY17 to 19, where we started at just about 37% viral load testing coverage, but we are now at 78%. This is a huge impact over the years, thanks to support not just from the PEPFAR team, but from the ministries of health and all the stakeholders that have worked together. So the next slide is looking at the same thing again, but we're trying to show individual countries so it's easier for us to appreciate. We can see that the countries on the upper portion of this figure are those who are doing extremely well in terms of the viral load testing coverage. Our target for last year was at 80% coverage. You can see that a lot of those countries have crossed the bar. But now we see that the countries on the lower portion are those that are doing well or the same, but again, they need to accelerate testing. So now we know where emphasis should be. And of course, we zoom into the countries and work with countries teams to identify the gaps and fill accordingly. My very next slide is looking now at virus suppression. You will recall that over the years, there has been impressive virus suppression in most countries. I think that's what we are seeing here again. Some countries, the one on the upper portion, have done so well. Our target is 95% virus suppression. A lot of countries are getting there. Some are actually above that bar, while others are also making progress. Next slide is now trying to look at the data, trying to age bands 15 years and above and below, which is usually a good comparison for us to see. You can see that if we're comparing FY18 and 19, for the FY18, it's same like 19. We don't see much difference in terms of the plus and the minus 15 for the coverage. It's almost the same, but there's a huge gap in terms of the virus suppression. And I think we've seen this in other data, implying need for emphasis on the other 15 in terms of the viral load suppression. Now, my very next slide is looking at the viral load coverage for pregnant women compared to the general population. We've seen a very, very strong and impressive suppression for pregnant and breastfeeding women over the years, but coverage has been a little bit low, as you see here. But I want to really say here that we've just come to realize last 2 weeks from our PEPFAR program that this is not truly the case. What we see is that these women are actually tested, they have viral load results, but I think it has been the way the data has been analyzed or classified and presented. It seems like most of the women are actually classified as adults and not necessarily pregnant or breastfeeding women. So we are improving on data systems, and definitely we're going to see a different pattern here. So what you are seeing here may not be the true situation. And I think we encourage our other programs to do the same, look at your data more accurately, develop better tools and analysis to disaggregate this data, and you'll see something a little bit different. So my next slide is just a summary of what I've been saying earlier. This slide actually puts us through the 95% suppression that I talk about. You see a lot of countries, both those on the left side of this figure are already getting there, some are above. But again, on the right, there's still a lot to be done. So again, we know where the issues are, and we continue to work with countries teams to address them. So again, we just want to still emphasize showing here the difference between the ages in terms of the virus suppression. The under 15 again is shown clearly here, and you see that as you move down right up to 1 to 4, you see a complete different situation. So there's a need again for more emphasis in this area. My very next slide is talking about the early infant diagnosis. Of course, when we talk about viral load, early infant diagnosis becomes very, very important. This again is a big picture showing us what we've seen over the years for the PEPFAR supported programs in countries. You can see again a very, very tremendous improvement looking at the yellow line. From 2014 to 2019, we moved from 45% coverage to 72%. Again, please, this is coverage at 2 months. This is why things are very, very critical and important for us. We don't lay emphasis on 12 months. 2 months is the way to go. So we've seen tremendous improvement in this area over the years. However, the next slide is now looking at the same thing, but now breaking down into countries to see which countries are there yet and which countries are making progress. So you can see that looking at the 95% target that we set for this particular activity, a lot of countries are struggling to get there, but making a lot of progress. Again, it gives us the opportunity to think about what are the issues and how to address them, what combination of testing strategies should be in place. Now, my next slides moving forward will really be zooming into the priority activities that we plan to support in COP 2020. The very first one, of course, again, I know there's a lot of interest here on the use of point of care instruments to support testing. So this one is something that we had in the COP last year, recommending that countries should consider the use of the point of care testing to support viral load among pregnant and breastfeeding women. We know that viral load suppression among these women has several advantages, apart from really an important opportunity to prevent vertical transmission. It's also very, very important for the health and the well-being of these women. So we need to take this very, very seriously. Again, looking at the figure on the left is what I showed earlier, that probably this is not a true picture because we need to improve on data systems and appropriately disaggregate data to see exactly where we are with these women. The very next slide for me, again, on the screen is the use of the point-of-care platforms to support infant virologic testing. This has been something that we've mentioned, I think, for the past 3 years in COP guidelines. We know the tremendous benefits of the use of point-of-care instruments from the pilots conducted by CHAI and ECPA with support from Unity. We've seen that happen, leading to things like reduction in turnaround time, reduction in pre-treatment, loss to follow up, things that we see all the time. So that recommendation stays, and we want to ensure that countries' programs think about it seriously. This is really, really new to us, to everyone. It's something that, again, is the first time we're including it in the COP guidelines. It's been well debated. This is now talking about the use of the point of care platforms for virologic non-suppressed patients. This is a population that we seem to be neglecting, but it's very, very important because we're not seeing tremendous improvement in suppression in countries over the years, which means a portion of the non-suppressed portion, the patients remain within that segment, and the number is not decreasing. So data that was shared from the WHO document that during the IS 2019 actually mentioned about just less than 10% of the non-suppressed patients having follow-up viral load tests. I think this data came from dashboard of a couple of countries. It's something that we need to think about seriously. The Medicine Sans Frontières also published data talking about less than 52%. However, we have scanned through our PEPFAR programs in country, looking at the high viral load cascade, and we've seen that it's the same. There's a huge drop from patients that go through the first, second, and eventually the third enhanced adherence counseling, and eventually those who get the second viral load test done. This is serious, but we've learned a lot in a couple of years, but most importantly, there is this publication from South Africa which actually has shown that improved enhanced adherence counseling could actually improve viral suppression. And the very data also shows that the use of a point of care testing can also improve testing among this population. We think what is most important here is also really to ensure retention of this population and ensuring that there's improvement in counseling and also the use of point of care instrument. So this is new, and we're encouraging the programs to really consider this as they work in putting together their draft COP guideline that will eventually be approved. Now, this is the very, very important aspect of our work, and I think PEPFAR has supported the HIV rapid testing continuous quality improvement over the years in most of the countries. We know that misdiagnosis is coming up. WHO has reported this, and we've seen this in many programs. More so, WHO talks about the need to repeat testing before initiation of ART. The evidence is that some countries are not doing this, more so with the recent test and treat approach where people are placed on treatment as soon as possible. So we want to ensure that the emphasis on the use of quality systems, implementation of the WHO PEPFAR initiative, which is the HIV RT-QII, and also, of course, the use of the checklists, the logbooks, they're all there. So programs should really ensure that they use this to minimize testing errors. My very next slide, where we are now, is the recency testing. This is something new, and the PEPFAR program has been expanded in so many countries. I think about 15 of our countries are now implementing recency. This is actually meant to differentiate HIV positive people recently infected and long-term infection. Again, I want to emphasize that this is not a diagnostic test. There has been some concerns, and people have really saying that we're using it to replace the national algorithm. No, this test is actually carried out for people who have been diagnosed HIV positive using the national algorithm. So the whole extent is to determine who is recently infected and long-term, and it helps to really tailor programs to where the needs have to be. You can see the figure on the right of this screen. That is the dashboard that we obtained from the Central American program. You can see that through the use of Recency, we're able to determine hotspots for HIV recent infection, so that when you're talking about HIV prevention, intervention, you can focus to those areas rather than being all over the place. Now, let's talk about supply chain, which we know over the years has been a huge issue. We've had challenges with excessive instrument procurement, instrument procured but no service contracts in place, reagents not coming in, stock out, and interrupted testing. This year, the PEPFAR program has launched what we call the request for proposal, which is the RFP, and the manufacturers have accepted this. So we are really encouraging country programs to support the RFP. Of course, it all leads us to what we call the all-inclusive pricing. From the past 2 COP guidelines, we insisted that programs should stop outright instrument procurement and go through the reagent rental or the all-inclusive pricing. That actually pushes part of the investment to the hands of the manufacturers. They should be responsible for this instrument installation and servicing and reagents, so that we can pay just cost per test. We've learned a lot from the UNICEF and UNITEST supported RFP that was launched last year in support of viral load testing in some countries. I think that should be the way to go. So there's a strong recommendation for all our PEPFAR program to consider moving this forward. I always use this next slide just to explain the importance of a holistic approach to supply chain. When we talk about supply chain, think about instrumentation and reagents, and consider this happening at the same time. This slide, the left portion is where you have A, is where there's instrument downtime, the reagents, but you see that has affected testing. On the right side of it, of course, the reagents, again, the reagents stock out, but the instrument is there. So we talk about a holistic approach, and we think that the all-inclusive pricing where one individual is looking into instrumentation and reagents is the way to go. So think about that as you move forward. Then, of course, over the years, the PEPFAR program has invested a lot in continuous quality improvement and accreditation. That, again, is still a focus, but not as in the past. I really want to emphasize here that we've been doing this for too long, and the understanding now is that at least this should have been transitioned to countries at a national level. But despite that, we still feel that there's a strong support for this. And of course, we want to ensure that there is accurate relay testing going on. And of course, that would lead to a decrease in testing interruption. We've seen this in many laboratories that have been involved in accreditation, sample backlog, turnaround time, errors, and so on. We minimize as much as possible. Then, of course, the diagnostic network optimization is something that we take very, very seriously. It's ongoing in most programs. And of course, the impact of really ensuring that this happen in country is in many, many folds. It has been shown to lead to increase in access to testing, of course, also increase in efficiency, decrease in cost, and also efficient allocation of resources. The figure on the right is an example of the PEPFAR-supported diagnostic network optimization that was carried out in Nigeria. This actually helped to reduce the number of laboratories from 27 to 15. And of course, the country is at this point implementing or trying to operationalize this new approach, including things like the sample transport system, improved data system, and visibility, and so on. So it is the way to go. This encouragement and the PEPFAR program in what we call the minimum program requirement for this year. We expect that each PEPFAR country should have done this, or they should come to the meeting with a plan on how to start conducting the diagnostic network optimization. More so again, of course, remember some countries have done this in the past, but with the introduction of the point-of-care instruments and the multiplexing, there's a need for us to revisit the entire exercise and make sure that there's efficiency along the path. And my next slide is, let me see. My next slide is talking about the need for us to consider use of the dry blood spots, the DBS, to improve viral load testing. We know that the best sample type for viral load is, of course, the plasma. But because of the need to move sample transport system, we encourage the use of DBS as the need arises. This figure is from the Malawi dashboard that shows how they decided to use DBS for viral load testing, and it led to, of course, improvement in testing. Apart from this, the COP guidelines has also improved emphasis that where the capacity exists, they should consider the use of DBS for sample collection for viral loads for the pediatrics population. I think there's a huge concern about not testing of the children because of the sample type. They are not able to use needles and so on. So there's emphasis to consider the use of DBS for that population as necessary. Next, of course, is what we call the multiplex use of platforms. There's a lot of emphasis. We're in Geneva with WHO in July for a meeting on diagnostic integration, where there's a need to consider using one of more instruments to support multiple testing. There's need for integration in diagnosis. This is an example of what actually happened in Zimbabwe. By 2017, this country had more than 130 gene expert instruments. And of course, the capacity utilization was very, very low, just about 27%. And they decided to go this way. And of course, they decided to use the same instrument for TB, early infant diagnosis, and viral load testing. And the outcome was very, very impressive. It led to increase in instrument utilization. Of course, that is expected. And of course, TB testing was also improved, and of course the oral testing of a TB alongside was not affected, because this has been some of the concerns about integrated or multiplexing, and of course it led to a faster and increased rate of clinical action. So there's a strong recommendation for programs to really move towards this direction. My very next slide, of course, is talking about the HIV drug resistance. This is something that is not been really emphasized, but we really want to make sure that that happens as we move forward. The PEPFAR approach is not the sort of the national surveillance that goes on over the years, but this time one is to be more targeted. It's a sort of a laboratory surveillance where all the remnants of viral load testing samples are kept. And of course, once that is viral load is carried out and patients who are non-suppressed, you select those samples and run resistance just on those samples. So it's more targeted. Again, it's seen to be one of the patient-centered approaches where you really look at all the patients and say who is not doing well and what is wrong and how can we quickly address it. So it's more focused, and again, it will be supported moving forward. Then, of course, the data system, and again, I don't want to really emphasize on this because this is critical for all the programs at different levels. We know about the Kenya system that, again, I'm presenting here as a good example, where they've started right from the facilities with the remote login. They have a good system right off to the laboratory, testing, improvement in turnaround time, and of course, very important is a dashboard, which is, again, helps to analyze and present data. We really encourage programs to think about this and move forward with this. Again, if we're talking about ensuring that every patient receives his or her results, then we need to have a very, very strong data system to ensure that this happens. Then, of course, I just want to present some of the considerations, lab considerations for advanced diseases. The use of CD4, of course, is strongly encouraged. PEPFAR strongly support the use of CD4 to actually identify patients with advanced diseases. But I want to say that we don't really support the use of CD4 to determine treatment eligibility or to monitor treatment. That should really be done with the viral load. The take here is that because of the need to scale up viral load, more resources should be geared towards supporting scale of viral load rather than routine CD4. But CD4 should be used as a need arises. In terms of instrumentation, of course, the point of care CD4 instruments have been there, the FAXPRISO, the PIMA, and so on. But more recently, there existed the lateral flow CD4 assay, which is, I know, is currently undergoing through the WHO pre-qualification. I think that is the way to go. That's sort of the rapid test that determines CD4 in terms of 200 or minor, below or above 200 should be the way to go. And of course, a strong support also for the TB, LAM. This has been going on over the years, but we've noticed that countries' programs are not really moving this forward. So we really want to ensure that, again, there's improvement in terms of the use of the LAM. And of course, the cryptococci antigen testing is also strongly supported. Now, waste management is something that we have emphasized over the years. And I'm happy that Anafi, who is actually leading this eco session, is leading our effort within the integrated diagnosis on this. So there should be strong emphasis on national policy on waste management, system to manage waste, routine waste, and of course, a strong coordination between the different stakeholders. And my last bullet talks about the GTC, the thiocyanide that we know is really a concern now for countries, particularly the waste from the gene expert cartridge and also for some of the Roche reagents. There should be a system in place to address this, particularly engagement of the manufacturers. Then, of course, I brought in this slide to talk about a global health security, that the notion here is that, PEPFAR brings in money through HIV into the countries, but there's a need to leverage this funding to ensure that it strengthens the entire country laboratory system. If we talk about accreditation, we're not just talking about the HIV platform, but across the board, talking about data system and so on. So we want to ensure that there's effective use of resources across the board to support global health security, integrate IHS, and so on. Things that we know that countries need should be seen as part of the overall health system strengthening. And this is almost one of my last slides. We have what we call the Diagnostic, Integrated Diagnostic Consortium. This consortium was established in 2017, just stemming from what we said earlier about the lack of coordination that has been over the years, which led to excessive instrument procurement, reagents, and all the challenges. So we're looking at what can make systems more sustainable. The most important part of it is coordination. So we have the Integrated Diagnostic Consortium that is made of the countries and partners listed. We've been working together. We met last July or September here in Washington, and we have an action plan to address a lot of issues, including supply chain, data system, waste management. The goal, of course, is stated here, is really to ensure that there is improvement in terms of coordination on interrupted testing, optimization, and insurance services for HIV, TB, hepatitis, and other services are happening in the countries. There's a link here to ASLM that is hosting the website for IDC, where you can go through this link and also see a lot of information that is helpful. So we strongly encourage country programs to stay within the IDC and work as a team. This is almost my last slide. Again, just talking about the timeline for the COP process and approval. As I mentioned, the COP guidelines went up out last week, January 15. And if you look at the timeline here, at this point, our country teams are meeting together with other stakeholders, the WHO, Global Fund, MOH. You can see that on the left side of this particular figure, you see what PEPFAR is expected to do, what stakeholders are doing, and of course the date. So this goes on right up to the February 17, where we start meeting with country teams in different areas. We'll meet in South Africa. Most of the countries will be coming there. Some will be in Asia and some in Washington or in Atlanta, where the countries will come in with their draft COP guidelines. And of course, again, it's not just a PEPFAR-driven activities. The Minister of Health and also the other stakeholders are part of it. It goes on right up to March 27, and of course beyond that we have the draft COP guidelines that is reviewed and eventually this is approved. Now in terms of when this take effect, it is from October 2020. So we're actually at this point implementing the COP 2019 activities and the COP 2020 that is being processed now, and eventually we approve in April or so. We start implementation in October. So this is my last slide. I want to thank ASLM for giving me the opportunity to share this PEPFAR lab priorities. And thank you all for listening. This time for questions and answer. Over.
Looks like we've lost net. Hello. Hello. Hello.
Yes.
George, can you hear us? Okay, thank you. Looks like our internet is a bit unstable, but we almost lost you when you were moving towards the end. Maybe you can stop the screen sharing. And many thanks for this wonderful presentation. And I must say, there's been a lot of demand indeed. A lot of our colleagues have failed to join in this session. It reached the maximum, and I keep on receiving messages for the request to repeat. So hopefully maybe we'll need to talk about that. But I think you have George has raised many important elements that are in there. So I would say to country teams, there you have it. The COP20 is here for us to make sure that we make the most of what is there. George mentioned issues of point of care testing, and he went into depth in the advantages and the efficiencies that we may be able to get, particularly pregnant and breastfeeding women, early infant diagnosis, which we know has been an issue in many countries. He also touched the issues of data elements in really making sure that we are able to measure our impact. Of interest that I also found was the element of point of care for non-suppressed viral load patients coming in there. We know there's a lot of investments that have been done over the past couple of years. UNITED, UNICEF, ASLM, CHI have put quite a lot of investments in there, and would be happy to see this moving forward as we look at COP20 and beyond, as well as the global fund issues. George also mentioned the issues of HIV rapid test quality improvement initiatives. We know we want to reach those milestones. We are talking of 90 by 2020, but of course we have those fast track targets, 95. As we are about to reach the station, the journey becomes harder and harder. So we need to pick the few positives that are out there. So, and most importantly, we need to make sure the quality of our testing will be important. Recency testing also was in quite some depth. Of importance, all these efforts will be up to no vain if we do not have the commodities. Of interest, the PEPFAR RFP that has been mentioned, we need to be thinking of innovative ways of getting our commodities. Maybe we should start sort of forgetting about just capital procurement of instruments, but have it as a package as well. George gave examples of these out there. The issues that we've always talked about in the world where resources are becoming more and more inefficient, more and more less as we try to get more, diagnostic network optimization becomes a key element. Examples of Nigeria provide that this can be possible. I urge you to go to the publication there and to see in terms of figures how much dollars are actually being saved and could be used elsewhere. We have complained that sometimes plasma is difficult to manage, but we also have options like DBS, and the Malawi study shows that this is quite possible in our areas where it may not be possible. Diagnostic integration, George referenced the meeting that we had in Geneva last year, and we continued at ASLM LabCoP meeting, and we have continued also at ICASA 2019. We need to give these patients all the care that they need at the point that they are. I think it's one of the ways of providing that integrated service. I cannot overstate data systems. And most importantly, we have been really discussing about waste management. We may all improve all these services, but if we are damaging the environment, if we are not paying particular attention to this, this becomes also an issue. And thank you very much also for outlining the COP approval process for our countries to really take note. At this point, I know there are questions in the chat box that we would like to take. We might not be able to finish all of them, but please do note that we will all collect these questions and actually get them to you if they are not all answered. So I would like to take, as we prepare to take the first few questions, I don't know if there are members of the civil society in the audience who may want to comment about what does this mean from the perspective of the recipients of care. Is there anyone from the civil society? I know our colleagues like Dennis usually attend. Are you there?
Yeah, I am. Thank you very much for the very good presentation. Maybe just to give a quick overview from the civil society perspective, we are very happy in Malawi for the involvement in the COP process, which we have been participating over the years, including the 20 COP process, which we are also participating right now. I wanted to give the comment regarding the viral load suppression to say indeed it is a very big issue. Here in Malawi, of course, I know even in some other countries, this is also a very big issue. As we are getting to epidemic control, if we don't really check on the viral load suppression, then we might end up not getting there. One of the issues that we have discovered as a contributing factor towards high viral load amongst clients is the issue of faith healing. I don't know how it is in other countries, but here is one of the big issues. We have men and women of God who are praying for people and stopping them from adhering to drugs or stopping them from taking drugs. So this is one of the areas as civil society organizations that we want to take it up and see to it that we educate these faith leaders on treatment literacy and also making sure that we mobilize communities and encourage them not to stop drugs even if they have been prayed for by men and women of God. Regarding the point of care, which he highlighted, I think one of the challenges that we have in Malawi when we go out in the district, in the health facilities, is the issue of understaffing. We have serious human resource for health challenges, and this poses a challenge in terms of provision of various services. And this is why this time around, we would also want to push PEPFAR or to advocate for the recruitment of additional health service providers, including lab technicians. We believe that if we have well-trained health service providers, including the lab technicians in our facilities, plus also adequate equipment, we should be able to provide good quality services as we move towards the epidemic control. So once again, I'm grateful to PEPFAR for the continuous engagement of the civil society, where we provide feedback regarding how we view things as recipients of care. And this helps in terms of programming, good quality programming.
Thanks a lot, Dennis. We always appreciate getting the perspectives of the recipients of care because they are the ones we are all doing this for. I would like to turn it to my colleague next to me here, Dr. Murray, the National Program Manager, National AIDS Control Program, Sierra Leone. He has a question.
Okay, George, I want to thank you so much for the very brilliant presentation. It has actually opened our eyes to what has been missing in Sierra Leone. We have a lot of challenges there. I mean, hearing a lot of things that are going on in other countries, it makes us want to actually reach where you are, although we have to take baby steps, but we need to reach there because there are some things that really we need to move forward with, especially with Recency, which is quite a new phenomenon for me, because we are having a lot of people who have been tested and they went out of the program, they got tested again. So we are having a lot of problems with that. I think Recency will be good for us, a lot of supply chain stockouts we have in that. We are also challenged with what to do with people who are not virally suppressed. So I think having a program and having people who have done it before, I think that will help us. I mean, learning from people who have done this before, that will help us to know what to do with the virus suppressed mitigation. And of course, we have challenges with the lab and with our equipment. So having people who have a lot of experience in the lab, in equipment, we have a lot of academic equipment, and we really want to see how we can have newer equipment that can work properly for us, and we won't have challenges with it. So these are some of the challenges that we have at the moment. The other challenge that we have is that we need to scale up. We have so many problems in the system and all of that. So I think with this, we will benefit a lot as a country from PEPFAR funding. But the problem that we have is that we have been chosen to be part of the first batch from February 17 to the 21st. The problem we have is that you are talking about the COP, the country operational, plan, country operational plan. And you were saying that the deadline for this has ended in January. So we want to actually move on to South Africa and see how we can work on this. But then if we have to work on it, we will need like the template or some guideline or some examples so that we can see how people have done it so that we can work on it. And also because we have we're talking about new inventions that we have not done here, we are still behind, so we're still so far behind, and we are still underfunded because our national strategic plan that we have, we only have 20% of funding from global funds. We have a lot of issues that have not been funded at the moment. So having PEPFAR helping us with these funds would be very, very good. And then we'll also need the presentation so that we can share it with the rest of our colleagues. And also it will help us to see how we can work on the COP or the presentation that we want to present as we move to South Africa in February 2020. Thank you.
Thank you. I think she mentions that they may need technical assistance in preparing for the application. I want to take one more question, then I'll let George respond. We lost a bit of connection, so I might have lost some questions, but they are obviously on the cloud, but I don't have that yet, so it's not that I'm forgetting. The first question that I have here is in terms of support towards multiplexing. Is PEPFAR allocating funding towards HPV testing among women living with HIV? Is PEPFAR allocating funding towards HPV for testing women living with HIV? Over to you, George.
Yeah, good questions, and thank you all for listening. Starting with the colleague from Sierra Leone. I know Sierra Leone has not been a PEPFAR-focused country in the past, so I know it's more recent that a lot of resources are coming in, so you may not be at the same level, but it's the opportunity there for us to quickly catch up. In terms of support, I would maybe want to know what sort of support you need, because I said the guidelines, the process is now that countries will be having a retreat. If your country is part of the countries, definitely there's someone like the chair of the program or what we call the program managers and the in-country team should be talking about what sort of resources do you need, and they should be in country and be part of the retreat process. I can get back to you one-on-one or get back to me if you need any additional support or some guides for us to fill. But so we look forward to how you put together your package and our meeting in South Africa. That said, in terms of the HPV, the PEPFAR program has invested a lot for cervical cancer testing, but our approach is a typical WHO recommended VIA approach. And of course, it will fully support the HPV, which is something that we're still moving forward. So we are actually thinking about doing that down the road, and we're working together with Unity to see how that can happen. But at this point, we are using VIA, but HPV is being considered seriously in terms of really targeting those who are suspected to have the cervical cancer. So.
Thank you, George. I know we are just passing the hour, but if we can be able to push in a few minutes, hopefully those that can stay, please hold on. GTC issues are becoming alarming. How can CDC, PEPFAR intervene to bring manufacturers to be more engaged in reducing or destroying GTC produced by their products? Want to comment on that, George?
Yes, Anafi, I thought you should better answer that question because you are actually the one leading all our efforts within the Integrated Diagnostic Consortium. In one of my slides, I said this should not be seen as a PEPFAR or a CDC issue. It's a global issue and has to involve all the stakeholders. So maybe let me turn over to you, Anafi. Tell us exactly how you're working with us and leading this process, working with CDC that has a lot of capacity and within the ITC. Can you just explain to everyone? Thank you.
Okay, thank you, George, for turning it back. Yeah, indeed. I'm glad that I think there's a lot of momentum moving on this one, as George has explained, through the Integrated Diagnostic Consortium, which is a multi-stakeholder platform. We have started actively engaging the manufacturers in seeing how best we can do this together. If you probably may be aware, we already have created a separate sub-community of practice where we are only dealing with waste management. We have already engaged manufacturers on separate occasions. Early this month, we actually had Roche on board, where they actually explained what they have on offer as we fight this issue. We also hosted Abbott sometime late last year, and we also had a roundtable with all of them in October. But these are just preliminary things. They, of course, have their research and development units that will eventually, like we all need, take out all these products out there. But in the meantime, we are working on solutions that could be stopgap measure to destroy these chemicals. We have best practice that have been tried somewhere. Issues like charcoal use, issues of incineration. Some have also tried to transport it to areas where incinerators are found. And I'm glad, like George has mentioned, there are organizations like CDC, they have a lot of capacity to try and work on this. I may not speak much to what they are doing now, but they are actively working out to see if there are solutions that could come out there. And we are hoping that somewhere along the way in these sessions, we could start maybe asking them to give some feedback on what are the possible solutions that are out there right now. So please join our sessions on waste management. And we are also working as ASLM with country teams to develop some work plans on short-term, medium-term, and long-term solutions to this. And we have some countries that have come forward that are actually moving forward. But we are welcoming all of them to engage with us and see if we can try to see one or two things that we can achieve over the long term. Next question comes from Rusubilo from Tanzania, I guess. He or she is asking, would you like to learn more from Kenya on how, would like to learn more from Kenya on how to address issues of confidentiality by sending HIV results via SMS. So I think maybe what we'll do is to connect you with the Kenya team. Then we can discuss on that. The next question is, if Pakistan, this is from Dr. Afrinish, if Pakistan can participate in strategic planning meeting for further wake-up. Hoping that I understood this one. I think he's asking whether Pakistan can be able to participate in the meetings for COP. Let me take one more question. It is said that CAPE-CTM 96 technology is going to be phased out. I would like to know if there were any processes to pre-qualify the 6800, 800, and 4800 for EID testing. I know this is a relevant question, but I think we addressed it a bit on the last session. I'm not trying to ignore these questions, but we would want questions that are sort of directly related to, I think, the COP processes. As we are advocating and considering moving to point-of-care viral load and EID, what is the take for the countries that have over capacity for the conventional platforms, which are underutilized for several reasons? Maybe, George, you can take it with reference to the case study of Zimbabwe that you mentioned.
Yes, so I think it's very, very important for us to really conduct what we talk about, a diagnostic network optimization, because what we've learned in a lot of programs that the access for both conventional and point-of-care instruments, and these instruments sometimes are placed in the wrong locations and so on. So when we conduct this exercise, we have to see exactly where they are placed and their needs. I think the issue here is that not that if you have 20 or 30 conventional platforms, you must use them. What happens if that is not supporting your program? What happens if there are places where the samples are not available to test and the transport system is not in place? What happens in student setting where you actually only need point of care, or in setting where it takes a long time for EID samples to form a whole plate for you to run using conventional platforms. So there's a need not to look at the existing instruments, but look at the instruments in terms of the needs of the program and redistribute accordingly. We end up having situations where some instruments become obsolete because they are just in excess, and there may also actually be need for us to procure some to meet the needs. So please, let's also again not look at what is in place, but what we see as an outcome of our DNO exercise.
Thank you, George. I'll let some people ask questions personally, since we've sort of lost them as we were trying to reconnect. Osborne, I remember there were questions from Osborne or Tieno. If you are there, kindly unmute and ask the question directly. Osborne. Osborne, are you there?
Osborne here. Thank you, George, for the very good presentation. And we look forward to the day you'll be visiting us on TDY in Kenya. A few quick questions. One is related to the all-inclusive reagent pricing that are currently at an advanced discussion stage. We are happy to have participated in the process. What are the key considerations to address some of the in-country policies and barriers that have led to long and extended lead times? An example in Kenya is where there's a requirement that all imports should actually undergo a pre-shipment inspection process at the port of origin. And again, the inspection can only be undertaken by a very few limited number of institutions, and that usually is a very lengthy process. Then in terms of my second question, in terms of the follow-up viral load testing for patients who are non-suppressed, and based on the data that you have shared, have you managed to make a nosedive into looking at the quality of data? Because what we have seen, especially in Kenya, is related to sample labeling, whereby there is minimal or rather limited understanding in terms of the labeling of the specimen requisition forms, whether it is routine, second, or a repeat viral load test following an initial testing requirement, because we highly suspect that could be a cause to which shows limited data on the second follow-up viral load testing. And the third, we know in the past...
Make it quicker, we are running out of time.
Thank you. So HIV drug resistance testing in the past has majorly been a surveillance activity. Is in COP20, are we now permitted to dedicate resources to support drug resistance testing for patients failing second and third line treatment regimens? Thank you.
Okay.
There you are, George.
Thank you so much, Osborne. In interest of time, I will be quick. I think on the first issue about the all-inclusive pricing, I think this is where we are saying that it's a joint effort that we have to work together with everyone. What you mentioned is typically something that is a country's responsibility to look into A to C, into the advantages, and think about how to address those sort of bottlenecks that will affect this process in country. We just came back from I think from Tanzania, where they were all very, very impressed with the all-inclusive pricing approach, but a little bit of concern for the fact that it is a manufacturer that will deliver the products directly to the laboratory, even though the country has a very good in-country distribution system. So it's not going to be one size fits all, but I think it's the country itself to really lead this process and see as something that is coming to improve its entire testing network. So that is what I think, and I think that is how we should move that forward. As concerns the non-suppressed patients, what we are seeing again, of course, I think the dashboard that was mentioned, perhaps Kenya was one of them, that there's a huge discrepancy, but you are right. Just as I mentioned for the pregnant and breastfeeding women, there could be issue of data collection and the classification. But the best thing you can do to really know where the problem is to begin to construct what we call the high viral load cascade. That cascade tells you exactly where the issue is. So countries should really put together that cascade to see where the little gaps are, and so they can address accordingly. The third question, what was it again?
Drug resistance.
Yes, actually, sorry, the drug resistance stuff. Yes, so again, we don't want that sort of broad, generalized national surveillance approach. That is not the way to go, because we want to be more targeted. It's geared towards identifying people who are non-suppressed and saying if there's a need for switch or just other issues to address. So moving forward, we encourage you to be more targeted rather than that sort of national surveillance. Thank you.
Thank you, George. We were trying to add the 10 minutes that we lost at the beginning. There are quite a lot of questions that are in there, and what we'll do, we'll collect these and share with them through our WhatsApp group and I think other channels as well. Maybe I will take one or two random questions from here. This one is talking about the importance. I am worried that, I think this is Danka Kaitwana. He or she says, I'm worried that the importance of CD4 testing is being underplayed here. Facts are pointing to the fact that there are about 47% of patients with CD4 less than 200 having no or mild symptoms and may be potential victims to advanced HIV disease. I feel there is need to revisit this step. Is concerned with advanced disease.
Yeah, I think that the issue here is not underplaying CD4. No one undervalues that. I think we'll just be talking about in case, in terms of what we see as being a lack of resources, where should we be focusing? We want to make sure that every segment is seen seriously. Viral load monitoring is the way to go overall for all patients on AROT. And we feel that at this point, with this resource constraint, we should again be targeted just to look at what can we do in terms of the 200 cutoff, which is important for advanced diseases. But the routine testing, I know it's WHO guidelines and policy moving forward. But again, at this point, we could have more resources to be more open. But again, even that 40-something% you're talking about, we've also used from our FEAR, the PEPFAR FEAR data, which is showing that things are coming down. More so when we're talking about the test and treat, that it will meet patients at the early stage of infection rather than waiting for too long. So all is on the table, but the resources don't permit for us to be all over the place.
Thank you, George. And I can tell you there are questions pointing to all the areas that you mentioned, from point of care, data systems, M&E, up to drug resistance. So what we'll do is we'll compile these questions and share with you, and maybe you can respond, then we'll share with the rest of the community. I'm sorry to say, I think we are almost reaching the end of the hour. And like I said at the beginning, there's been so much demand, and I can tell there are many people who could not manage to join. So maybe we may need to discuss further how best we can do this, and try to see if we can disseminate the information as much as possible. And thank you very much for staying until, I know you stayed until the end. Those that could not join, I think we'll speak to them. Just a couple of announcements to the ASLM LabCoP country teams. We are currently reviewing your work plans. Some of them we have already given feedback, and it's important that you have also listened to the issues that George talked about. It's important to have work plans that are tied to funding, and then those become actionable for the results. Otherwise, let me not take much time because we've gone beyond the hour. I just want to give 30 seconds to George to give final remarks before we close.
Yeah, thank you so much again to the entire team of ASLM and everyone listening. It's an opportunity for me to have shared this very out brief from the COP guideline that just came out. I know now people have more questions to ask because they have not had the time to read and go through this document. I remain open to answer all the questions. For all our PEPFAR colleagues, they know me, they have my contacts, you can get back to me one-on-one. And of course, I will be in South Africa for the entire 3 weeks of this meeting. I will be roving around and I will answer all the questions. Also, our colleagues from the agency, from CDC, from USA, they're all our lab colleagues. They have a lot of knowledge on this. They can get out there and help you as much as possible. So we look forward again to a strong collaboration between everyone. And most importantly, again, I think our platform or the forum is the IDC, where we can work, and we're going through the IDC and working as a team can be more cost effective. So thank you all, and I will look forward to next opportunities to continue to discuss and share all this knowledge. Over.
Thank you, George, and thank you all for joining. We shall be communicating in the next few days regarding the next steps, as well as the topic of next month. As usual, we do it in the last week of the month. Thank you very much for listening through, and have a good day, good morning, or good evening, depending on wherever you are. Thank you, and bye-bye.
Thank you too, and bye-bye. Have a nice day.
Bye.
Thank